All right, good morning, everybody, and welcome to another MRI session series here at VCU. Today's session, we're going to talk about imaging in hypertrophic cardiomyopathy. My name is Mohammed Makkiya. I'm one of the non-invasive cardiologists and cardiac imagers at VCU. And I'm the director, and I run the Hypertrophic Cardiomyopathy program here at VCU. Want to welcome you here, and we're going to talk about imaging in hypertrophic cardiomyopathy. So I have no significant disclosures to this talk. So first of all, as I always like to start my HCM talk, is talk about the history of this. This was first discovered in the 1950s, almost 70 or 80 years ago, by pathologists and the London coroner back in the 1950s, Dr. Donald Keir, where he did an autopsy series that he published in 1957. Here we have it in this document, where he accurately described hypertrophic cardiomyopathy and the so-called myocardial disarray. And till now, this is an accurate description of the disease. At the beginning, it was thought this is to be a tumor, and then later on, we figured out this is like kind of a genetic disease. Pathophysiology of this, it is inherited in autosomal dominant fashion. It affects the sarcomere, and it is associated with mutation in the nucleotide sequence variants that encodes the thick and thin myofilaments, compromising the contractile components of the cardiac sarcomere or disease disc. This is where the beta heavy chain and myosin binding protein genes are mostly involved. This is the histopathology of the disease. On the top left corner, we see the normal parallel low extracellular space or whites, basically myocardium in a healthy heart, versus in B, we see this starry kind of like Van Gogh starry star painting, where you have loss of configuration and architectural, like parallel architecture that you see in myocytes in the heart, the so-called myocyte disarray. You see is a zoom picture of that. The distribution of hypertrophic cardiomyopathy is worldwide, represented here in this picture from a study, from a review done by Marin, by the Marin family. It's represented in all countries. It has been described in 122 countries, accounting for about 90% of the world population, with a prevalence of at least one case to 500. Now, with the new modern technology, and as we are investigating and known more about the disease and the use of MRI, the prevalence has increased to 1 in 200 cases, making about 20 million of people affected worldwide. Also, what is important to take from this, HCM is still a very under-recognized disease, as many reasons for that, due to the lack of knowledge and other parts of the world, even here, lack of advanced imagery or availability, and definitely some of it goes undiagnosed, like because of the lack of symptoms. And that's why we should be on the lookout, especially in the family history, and increase the awareness about screening and evaluation for that. So how we diagnose HCM? This is comes from the recent ACC/AHA guidelines, which is define HCM as a maximal end diastolic wall thickness of 15 millimeter mercury or more anywhere in the left ventricle in the absence of another cause of hypertrophy in adults like hypertension, aortic stenosis, kidney disease, athlete hearts. The measurement is obtained by echo and cardiac MRI mainly at end diastole, which is the gold standard. Cardiac CT can also use and obtain these measurements. However, it's not a common practice as this may require contrast and radiation and more radiation. We have to do it in a retrospective fashion. Add to that the poor temporal resolution of CT compared to other modalities, but it can be done. So what is the differential diagnosis of hypertrophy? As I mentioned, hypertensive heart disease is a major player, aortic stenosis, chronic kidney disease, athlete heart, and infiltrative disease like amyloid and storage metabolic diseases like Anderson Fabre's, Danon, Pompe, myotonic dystrophy, Noonan syndrome. Some history about imaging. I like this slide showing the central role of cardiac imaging in diagnosis of hypertrophic cardiomyopathy throughout the year, how we started and how we end it now. This is the work that pioneered most of these imaging technique was done by the Marin family and Dr. Braunwald throughout the year. We see in the 1960s, we used to use angiography and invasive hemodynamic measurements and evaluation of HCM. Then in the 70s, mode echo came measuring the LV thickness and detecting SAM. Then in the 1980s, the introduction of 2D echo in evaluating HCM and measuring the LV dimensions in parasternal long axis views or short axis views comes to that. Then in the 2000s, early 2000s, where the first generation MRI, the workhorse for evaluation of the heart dimension, came up, was utilized to evaluate the heart. And then in the 2000, after 2010, the second generation MRI were used that used gadolinium or contrast used to enhance the dimension, LV dimension measurements, detecting fibrosis and scarring, and ultimately health and risk stratification and prevention of cardiac complication, including sudden cardiac death that led to the change in the guideline, in the recent guideline in 2020. So the first imaging test we use is an echocardiogram. Echocardiogram is the mostly readily available and easy to use, cheaper. You can use it anywhere. Now even we can use it like in our pockets with the new handheld devices. There's the ability of using spectral Doppler to measure the degree of LVOT gradients obstruction and to assess the severity, which is the gold standard. Also to evaluate valvular disease, including mitral valve and mitral regurgitation. It helps in guiding management for symptomatic cases, as we can use stress and diagnosis of provocable obstruction with exercise when we use stress echocardiography, when we are not sure about the symptoms or the degree of obstruction. It also has a role in risk assessment, prognosis, and definitely family member screenings. We use transesophageal echo. This is mostly transthoracic echoes. We also can use transesophageal echo where the images are not optimum with our transthoracic echo if you want to really look for an obstruction. or SAM, and you cannot see it very well on your regular echo or MRI. And you want to really evaluate the mitral valve, papillary muscles to plan for surgery, or we can use it in septal ablation to look for targets. Echo is, as I said, is the first modality in evaluation of patients with suspected HCM. We use it to determine the significance and the phenotype of hypertrophy. It helps to guide to evaluate the myocardial function and to establish the severity of LVOT obstruction, where significant obstruction diagnosed when the LVOT gradient is more than and equals to 30 millimeter mercury at rest or 50 millimeter mercury with provocatable maneuvers like Valsalva or exercise or giving amyl nitrate. Keep in mind that we have very important that we have to sample these velocities accurately. Sometimes these can and we should differentiate the dagger shape mid ventricular obstruction velocity from SAM and mediated LVOT, as we see here in the picture, from the mitral regurgitation velocity, as these can combine sometimes and affect our reading. But mitral velocity has a higher and a longer duration spanning through the isovolemic contraction and relaxation, not like the dagger shape LVOT velocity, where it's prolonged and then peaks up suddenly. Echo also help in evaluating other velocities when you have intercavitary gradients, whereas like from the hyperdynamic LV at the mid ventricle on the apex, this is not obstruction by definition. Also, like echo has also an advantage in evaluating the degree and direction of mitral regurgitation and internal structure of the mitral valve and papillary muscle. As mitral regurgitation caused by the LVOT due to systolic anterior motion of the mitral valve usually results in almost always, I would say, results in a jet direction that is posterior, like we see here, or lateral in orientation, and predominantly late in systole. Where our central, if you have central and anterior jets with obstruction, that tells us there may be an intrinsic mitral valve pathology or subvalvular pathology causing this on top of SAM. Let me play these. So also echo is an important thing to make, that the echoes help, as we see here in the lower left picture. You can see the SAM and LVOT obstruction, flow acceleration jet, and LV hypertrophy. That really helps in making, and we can know the severity by doing spectral Doppler. One thing to mention about echo, that we always echo, sometimes you have limitation about seeing the apex of the LV due to the artifacts that you get from the rib and the fascia, chest fascia. And then always make a habit about using echo contrast in diagnosis apical hypertrophy, as you can miss it if you don't use apical contrast. Also, using the apical contrast, as in this picture, we can see there is aneurysm of the apex with the apical wall plot or thrombi. So very important to, if you have a suspicion for apical HCM, you want to make sure that you have to use contrast to really thoroughly evaluate the apex. Now, MRI, although echocardiography is the workhorse of for diagnosis of HCM for the reasons I stated earlier, MRI is the imaging modality and the gold standard for evaluating the patterns, the magnitude of HCM, phenotypes, and accurately measuring the dimensions, and gives us also a prognostic information. Cardiac MRI has a very good spatial resolution compared to echo, and we can characterize the entire LV myocardial segments. Add to that, it has the best contrast resolution with sharp contrast between the bright red blood and the dark myocardium, which allows us to do precise LV wall thickness measurements. Than echo. Moreover, MRI also does not follow geometric assumptions like we do in echo, and you can really be parallel or perpendicular to the LV mass to get an accurate mass diameter or cardiac myocardium diameter evaluation. Moreover, mitral SSFP imaging and cardiac MRI can detect other abnormalities associated with HCM, such as the presence of congenital ventricular outgouges, recesses, diverticular aneurysms, clefts, creps, anomalies in the mitral valve apparatus, and abnormalities of the papillary muscles. Late gadolinium enhancement imaging provide a non-invasive tissue characterization by identification of the hypertrophic cardiomyopathy associated interstitial fibrosis. Phase contrast imaging or flow sequences can be used to quantify the outflow tract peak systolic velocity. Also can help to evaluate if there is concomitant aortic valve disease. Also, MRI can, like blood MRI, can be used to assess the diastolic filling velocity, obtaining curves similar to those of echocardiographic Dopplers. So in this slide, we see the known phenotypes of hypertrophic cardiomyopathy and the importance in making that distinction and differentiated the different phenotypes. On the left, we have the most common type, which is the sigmoidal septal hypertrophy, which makes about 50% of hypertrophic cardiomyopathy phenotypes. This is also seen in particular in patients with hypertension or elderly, making the diagnosis of HCM difficult for us. Especially only 10 of these have positive gene testing. You also see in the second picture is the reverse curve morphology. That's the one who has the mostly positive gene testing, about 80 to 90%. And then we see the third picture, the apical HCM, which causes about 10% of HCM. And then the last one, you have the concentric HCM, which also compromise about 10%, where you have almost equal thickness of the entire myocardium. And you can have mixed pathology. You can have mixed septal and apical with apical predominance. You have concentric hypertrophy with the septal predominance. So with the introduction of cardiac MRI, it really helped us to enhance our diagnosis and management of hypertrophic cardiomyopathy. For example, it led to a better assessment of the left ventricular dimensions than echo. enhance the risk stratification for sudden cardiac death with the introduction of gadolinium, contrast, and calculation of scar burden. And then we can easily recognize the different phenotypic expression. Sometimes that is not very well recognized by 2D echocardiography. These MRI pictures that I'm showing here shows different phenotypes of HCM. The first picture, there is a mid-septal that extends into the RV, while in B, we have the apical mid HCM, or used to be apical HCM, with the apical aneurysm, which is very important to identify, as this can be associated with high risk of monomorphic VT and sudden cardiac death. And in picture C, we can see the anomalous direct insertion of the anterolateral papillary muscle into the anterior mitral valve. And MRI can evaluate the associated papillary muscle abnormalities, and that really helps also in surgical planning. Correction needs to be made. D, we have the elongated anterior mitral valve leaflet, which causes SAM. In E, we have multiple accessory and hypertrophied papillary muscle, which can contribute to obstruction and of the outflow tract. And finally, picture F, which I showed here, when we don't see hypertrophy, but as you see in the arrows, there are these myocardial crypts seen in the posterior left ventricular wall, inferior left ventricular wall, which can serve an evidence of, research shows that these can serve an evidence of positive genetic status in a family member whose genotype results are negative or genetic test is not yet done. It's kind of a precursor for hypertrophic cardiomyopathy. Comparing phenotypes and measurements between echo and CMR is not like comparing apples to oranges for the most cases. It should be similar. We are comparing the same thing. However, the technique is different, which caused the discrepancy in the measurements. And there is a variety of reasons for that. Technique is different. You're assuming geometric assumptions in echo, different in spatial and contrast resolution. This is a bland Altman figure for this study, showing the distribution of disparity between echocardiography and cardiac MRI along the full range of measurable LV wall thickness. LV wall thickness indicates the left ventricular thickness that shows that echo can really under or overestimate your relative wall thickness and degree of hypertrophy. And this can impact our management and further consideration of our HCM patients. So areas where echo can underestimate LV wall thickness is the anterolateral LV wall, posterior wall, the apex, and this can be from the, as I said, the artifacts that we get, if it's in the apex, the fascia, and the ribs, that we need to be very vigilant in looking for these and use contrast to really identify it. And then, like you have in echo, the spatial resolution is not as good, and contrast resolution is not as good in MRI, and you cannot really see or can sometimes differentiate the RV structure from the LV structure. Here we can see some of the advantages of cardiac MRI over echocardiogram in differentiating different phenotypes of HCM that sometimes underestimated by echo. As we can see in the AB picture, hypertrophic cardiomyopathy can be focal. And if it's in the anterior, maybe anterolateral wall, where you cannot see that in echo, you can miss it. And then MRI can, as we see in picture B, really showed it very well. That also goes in the picture E and F. And you can accurately measure the thickness with the MRI, not so with the echocardiogram. And then in picture C and D, it's clearly the patient have apical hypertrophy in picture D. Versus in echo, you don't see the apex that well, and the quality is not very well. And we may really miss the diagnosis if we haven't be looking for it, or if this is a patient we don't know anything about and just do echo. We really need to use, and if we have, we can easily miss the diagnosis unless we use echo contrast. And even with that, you may foreshorten the apex and not see it very well. So always MRI has becoming more and more the most important test after echo in evaluating patients with ACM. And having said that, we can also, like, the degree of LV muscle wall thickness can be overestimated with echo, even sometimes with MRI, with the inclusion of LV and RV muscle bundles into the left myocardial measurement. And this can impact our consideration for management in the future. Like for this example that I'm showing of a case we have here, very common tendon that we see, the crista supraventricularis, which is an RV muscle bundle, with sometimes can be difficult to differentiate from the LV septum. And if we include that in our measurements, as we see in this picture, we can really, really overestimate our LV thickness to the point that it crosses 3, that signifies risk of sudden cardiac death, and versus this is just overestimation because of the crista supraventricularis. Very difficult to identify these in echo, and versus MRI, you can, if you really, you can really tell where the crista supraventricularis, and you can really measure accurately. So when is CMR recommended for ACM patients? This comes also from the guideline, the recent ACC/AHA guidelines. So CMR should be done in patients who suspect to have ACM, who have diagnostic or non-diagnostic or inconclusive echoes. For patient with LVH, and there is and you are trying to work up the diagnosis of hypertrophy, for risk stratification for patients with sarcomeric HCM, and evaluation for sudden cardiac death, and ruling out apical phenotypes, aneurysms, or apical clots in the aneurysms if it comes to that. And in genotype positive patients with relative normal wall thickness by echo, particularly if they have abnormal EKG, because about 5 to 10% of these can have focal hypertrophies, and you may miss it with echo. So if you have an abnormal ECG in your screening in a family member, then you should consider, and your echo is normal, consider doing a one-time MRI to make sure you're not missing a focal hypertrophy. I would say MRI should be done in every patient who have hypertrophic cardiomyopathy, This is, as I said, evaluate the magnitude and phenotype of ACM, identifying patients with non-obstructive HCM at risk of end-stage heart disease, risk stratification for sudden cardiac death, other forms of prognostication like LR structure and function, and help differentiate in other mimickers of sacromeric HCM. So, identifying EF in hypertrophic cardiomyopathy because of the pathophysiology and the increased acting and myosin cross bridges is typically hyperdynamic. And we consider normal EF in hypertrophic cardiomyopathy is about like 60-65%. That's because of the hyperdynamic function in these patients. So we consider substantial systolic dysfunction in hypertrophic cardiomyopathy when the EF drops less than 50%. And that's synonymous with advanced heart failure, like one regular patient when the EF is less than 35%. And this happens if it is truly due to disease progression from HCM, is usually due to the extensive replacement fibrosis, and CMR can be playing a big role in showing that and showing the degree of fibrosis in patients who have hypertrophic or sacromeric hypertrophic cardiomyopathy who drop their EF, not secondary due to arrhythmias or other things like coronary artery disease, but truly due to the disease advancement. And will help in the treatment, importantly. In this study done at Tufts University that showed ACM patients, when the EF dropped to less than 50%, it is associated with 6-fold increase in sudden cardiac death from ventricular arrhythmogenic events. We also see that patient had worsening on their symptoms progression, and it is associated with higher mortality. In such patients, ICD should be considered for primary prevention. Also, heart transplantation evaluation and starting the ball rolling early and consideration should be started, as it will help with their symptom control, and overall it has a mortality benefit. As studies showed, these people has a mortality rate of 11% per year, or even if they are less than 40 years of age. So really, you want to monitor them closely and start thinking about heart transplant and send them to an ACM and transplant center. So can work them up and start that process soon. Here is a study by Dr. Chad that showed with the use of cardiac MRI, patients with normal ejection fraction and extensive fibrosis, about more than 20% of the LV myocardium, has a 3-fold increase in developed end-stage HCM over time. So important to take note of that. So the the risk, this is also like from the ACC/AHA guidelines, recent one, shows the risks for sudden cardiac death. And most of these are imaging diagnosis, and MRI also plays a big role for that. The indication for primary or secondary prevention ICD if you're having a high risk features. What are these features? If you have definitely a prior event, that's a class 1 indication, or at least one of the following, where you have family history of sudden cardiac death, if you have massive LVH, more than 3 centimeter, unexplained multiple syncopes, apical aneurysm, and truly EF less than 50% in the absence of other causes. This is a class 2A indication. Most of these, except the first one, is all imaging diagnosis, and MRI play a big role in that. And then you have the monitor that's showing non-sustained BT that is fast and frequent and longer in duration, not your typical 3 beats. And finally, the extensive LGE or on cardiac MRI, defined by more than 15%. These are class 2B indication. Okay. So imaging again plays a big role in these, and this you need to do it frequently for patients with HCM, as this their sudden cardiac death risk can change with time. So in this column chart, we see the progressive increase in the rate of aborted sudden cardiac death and events in a cohort of around 1,700 patients. Significant greater rate for those with massive LV hypertrophy with a wall thickness of 30 millimeter, around 3% per year for SCD. MRI again can play a major role and provide accurate measurements in these patients, especially those with also focal hypertrophy, where echo tends to underestimate or overestimate if it comes to that. With the cardiac MRI, we can evaluate for late gadolinium enhancement, which indicates areas of fibrosis in hypertrophic cardiomyopathy patient. We can also quantify or measure the amount of LGE and the percentage of the LGE of the total myocardial mass. Bear in mind that about 50% of hypertrophic cardiomyopathy may have negative LGE. This study is an example of that evaluated the prognostic ability of late gadolinium enhancement for sudden cardiac risk stratification in patients with sacroiliac HCM. It's involved about 1,300 patients, followed them for several years after their cardiac MRI in multiple centers across US and Europe, showing the prognostic importance of late gadolinium enhancement in HCM. We see the freedom from SCD events is more in patients who have no or minimal LGE burden in this histogram below. And it's showing positive relation between the amount of LGE and the incidence of SCD events. And the more LGE, the higher the sudden cardiac death events from arrhythmias. Here, another group, here the same group, showed that the extent of fibrosis increases the risk of SCD. And at 15%, there is a twofold increase in sudden cardiac death and arrhythmogenic event, which is 6% over 5 years. And in these patients, an evaluation of ICD for primary prevention should be considered. And this is also confirmed by a meta-analysis published in JACC, showing a hazard ratio of 1.6 with 15% of LGE of the myocardial mass. We should really try to quantify the amount of LGE and mention that in our reports, as this really help and guide the treatment. And again, I would say when these patients come to my clinic, if they only have LGE, it's a class 2B indication, so it falls into your clinical judgment, the overall clinical patient complaint. And then if there is any presence of other risk factors, to push them for the ICD or do a shared decision making with them, explaining the need for ICD. Apical HCM is characterized by the lack of apical tapering and the presence of precordial T-wave inversion and cavitary obliteration of the apex. It can be classified into true apical or pure apical hypertrophic cardiomyopathy, or mixed, where there is a septal and apical ACM, with the apical being predominant, and finally relative ACM, where it is not pure apical hypertrophy, and the apex is thickened but does not cross the 1.5 centimeter thickness. Relative apical ACM was originally considered benign, entirely benign, but recent data suggests it associated with if it is associated with pathology and complications down the road, like LA dilatation, apical aneurysms, and the development of apical myocardial scar. About 15% of apical hypertrophic cardiomyopathy will develop apical aneurysm. Apical aneurysms define as discrete, thin-walled, dyskinetic segments of the most distal portion of the LV with a relative wide communication to the main cavity in diastole. It is hypothesized that these apical aneurysms and obstructive pathology arise from regional myocardial scarring caused by repetitively exposure of the LV myocardium, LV apical myocardium, to increase LV wall stress and high systolic pressures that lead to pressure overload, increased oxygen demand, and impaired coronary perfusion and ischemia or microvascular ischemia. So repetitive stresses causing microvascular ischemia. These will become heavily scarred and result in blood pooling and may confer a risk of apical thrombus formation, and this can be thrombogenic, causing strokes. These also can cause cause monomorphic VT that can lead to sudden cardiac death, LV systolic dysfunction, and heart failure. These aneurysms are not routinely identified on echo, as I mentioned before, and you really want to do MRI to really identify them. These are, as they are associated with ventricular arrhythmogenic events, mostly VT, as we've seen in this study done by the Tufts group. When they present, they confirm about 5% yearly risk of arrhythmias and sudden cardiac death. And based on that, the placement of primary prevention ICD should be considered. I would add, if you see apical aneurysm, even in the elderly, it's also like have a higher risk of VT. If these patients have a recurrent monomorphic VT, these are the one of the ACM subgroups where VT ablation can be very effective by targeting the transitional point between the scar tissue and the apex, thick myocardium in the middle LV wall. MRI plays a big role in helping our EP colleagues about finding and planning for this ablation. And finally, these, as I said, these areas are very akinetic and immobile, causing blood pooling that can be an nidus for clot formation that leads to thrombogenic events like strokes. And MRI is very effective in detecting these thrombi. As we see here in this picture, we miss it, sometimes even miss it on echo contrast if it's small, versus you can really see it on MRI. So the Dr. Marin published a prospective study of about 500 patients where it's shown that the atrial volume greater than 118 ml or an ejection fraction of the left atrium less than 38% may be predictive for the development of AFib in patient and has a worse prognosis. MRI can really help us in evaluate LV function and structure in these patients. Here's a cohort of about also 500 patients where the clinical outcome of hypertrophic cardiomyopathy for patients first evaluated at more than 60 years of age were followed on the span of the year. Sudden cardiac death is not the major driver for mortality in elderly patients. In contrast, the most common cause of mortality in elderly in patients with hypertrophic cardiomyopathy is complications from stroke due to atrial fibrillation, underscoring the importance of early detection and consideration of AC if you see atrial fibrillation ACM patients. Also, AFib tends to do war. Also, patients with ACM and has AFib tend to do worse if they have symptoms, and their progression of the disease is faster, as the disease ventricle is depend on the extrahull that gets from the left atrial kick. That's why MRI can also help us with that by evaluating left atria. MRIs also can detect mimickers of sacromeric HCM. We can have differential reasons to have left ventricular hypertrophy. This can be MRI can be of a big help to help us to differentiate these mimickers. We have the diastolic SSFP CNA images in the top row, which correspond with the late gadolinium enhancement images on the bottom row of these four cases of LVH. We can see some specific enhancement patterns that aids in the diagnosis. Asymmetric hypertrophic cardiomyopathy imaging showing hypertrophy of the mid-septum with corresponding fibrosis in the septum mostly, or the hypertrophied area in the first picture that's commonly seen in hypertrophic cardiomyopathy versus images showing more concentric hypertrophy with some patchy, non-specific, non-significant or non-burdensome left gadolinium enhancement. We typically see this in hypertensive disease or aortic stenosis disease, versus in amyloid, we see more of a concentric or asymmetrical septal hypertrophy, and we see the typical enhancement patterns, which is more extensive and patchy or more extensive subendocardial, and we can see the difficult nulling or in our T1 scouts. This is also associated with pericardial effusion, which you rarely see in sacromeric HCM, restrictive pattern early on with LV failure, and diffusely elevated T1 values, versus the last picture in Fabry disease showing pronounced circumferential hypertrophy with a prominent focus on the mid-wall fibrosis in the intralateral and the basal infralateral wall, as we see here by the arrow. That's where like typical fibrosis pattern for Fabry. And this, when you do maps on that, your native T1 maps is not ever elevated. It's actually diminished due to the presence of fats. I would conclude here without showing these cases in regard to time, so I can take a couple of questions because I have to run to Tappahannock. So thank you for being here. I hope this can help, and feel free to reach out to me if you guys have anything in the future, or if you have any patients you want to ask about, or thank you for your listening. Let me put the CMA slide for the code, and I'm open if you guys have a question or two before I leave.
Hi, Dr. Makkiya. This is Leela. One question. May have missed this part. In what percentage of patients you might find a genetic clue as if this is a really familial form of hypertrophic cardiomyopathy or else?
Yeah,
Like how
thank you,
much
Leila.
genetic testing help?
Thank you, Leila. Very, very excellent question. Genetic testing, even if you have a phenotype for HCM and it's a sacromeric HCM, it's only positive. If you test all these patients with phenotypically positive HCM, about 30 to 40% of the time by best estimates. About 60%, they will have what we call the non-genetic sacromeric HCM. And that stems from many reasons. The way the gene testing call like the pathologic genes, some genes that we have discovered, sometimes we have genes of inconclusive significance. They are not pathognomonic, but we need to do cascade screening for the patient family to see if we have a lot of this in the families, and we call it pathognomonic mostly. So many reasons stems to that. Out of the phenotypes, the picture that I show, that the most common one, the sigmoid one, hypertrophy has the lowest gene positivity, about 10%, versus the most one that comes with the gene positivity is the reverse curve, about 80%. So phenotypic expression also can be associated with that. Gene testing can help me sometimes in making the diagnosis if I'm not sure about cases. And it only helps if it's positive, to tell you the truth. If it's negative, it didn't add anything to me. But if it's positive, can really help me in making the diagnosis for, cases, patients who have HCM and hypertension. And I'm not sure if this is truly HCM or hypertension disease. If it's positive, then I can say there is like an hypertension is playing a role, but there is a genetic HCM. And it helps in family screening if you have somebody who's gene positive. And that's the main reason we use it.
Okay. I have one more question. When I come across cases undiagnosed and they are suspicious for hypertrophic cardiomyopathy versus, let's say something else, like let's say changes related to hypertension. If they're VCU patients, I usually suggest that they are being referred to HCM clinic. But let's say if they're being managed elsewhere and we want to suggest a follow-up pattern. Is there a conventional way of doing so, or do you have like a kind of a criteria or suggestion for what to say in terms of like follow-up, 1 year, 2 years, depending on what the mass or fibrosis is, or is there something that helps us to find out an right interval for follow-up?
Excellent question. Really very, very important question. It's always a struggle. Like, these patients who have hypertension, not very well controlled, and they have the hypertrophic cardiomyopathy that's very thickened and crosses the one, and like hypertension can make your septal thickness go up to more than 1.5 centimeter. But, like things to look and like definitely you have to take the whole picture. This needs to be seen by a doctor, like by the cardiologist, and they need to take the clinical picture, the symptoms, family history into consideration, other testing, blood testing, all of that, and perhaps doing a gene testing and a monitor to see, because hypertension doesn't cause you to have significant arrhythmias. It can cause kidney disease. These patients who have uncontrolled hypertension for years, they may have kidney disease. So you need to take the whole picture, not only the imaging part of it. It's a whole deal, basically.
Mhm.
Uh, in MRI, things like hypertension can make it septal thickness to go 1.5 centimeter, but rarely it crosses like 2 centimeters. If it's more than 2 centimeters, there may be a sacroiliac component to that, or something else is contributing to hypertension. Extensive replacement fibrosis, you don't see that in hypertension that is non-coronary, basically. It's definitely something really, patchy interstitial fibrosis, these wet areas you don't that you see mid wall, not significant, could be from hypertension. And then other things that you don't see in hypertensive disease is the LVOT obstruction. So if you have elongated, if you have SAM, elongated anterior mitral wall, systolic anterior mitral valve, and obstruction, you don't see that typically with hypertension. You see it more with sacroiliac hypertrophic cardiomyopathy. Now, for these people, and in the end, you may not know. Like I do gene. This is one of the reason. If I see like no obstruction, the wall is almost close to 2. A patient has uncontrolled hypertension for years, and I'm not sure. The scar is not significant. It's patchy, and I'm still not sure. Like so, I do gene testing for them to see if they have a positive gene, and then I keep an eye on them. Like, if you can try to control their blood pressure really well, and then get them back in a year or so and repeat the imaging, repeat the echocardiogram. If it's hypertension, it should come down, or it should definitely not, it's not a progressive disease. And for screening for these patients, the guidelines has very good recommendation about that. Like patients who have hypertrophic cardiomyopathy, you should see them once a year in the clinic and do screening. Definitely, the reason also for screening is to monitor the progression of the disease. If it's getting thicker, getting more heart failure, getting more restrictive, uh, uh, and uh, and then evaluating for sudden cardiac death, because this can change. Your risk can change at any time, and that's I would do yearly echoes on them and monitor, and maybe repeat the MRI on them in like 3 to 5 years to see, which is usually typically what the time, if you see a progression of the scar, it can happen within 3 to 5 years. So definitely these people need to be monitored and seen, and take the thing as a whole deal. The imaging helps, but it's not only the answer. It's like a piece of the puzzle. You have to have like the whole thing to really try to get closer to the diagnosis.
Okay. Thank you so much.
Okay, guys, I think we reached the hour mark. Thank you again for your listening, and we'll see you with another MRI conference. Sorry, Corey was not unavailable today, but he will be back soon. Have a good day and take care. Bye-bye.